Today, our lecture is about drug therapy of anemia. With you today, Dr. Sameh Ahmed Abd. Our ILOs for this lecture will include name the most common types of anemia, list factors affecting the absorption of iron, compare between different iron preparations and toxicities, identify the interaction between folic acid and vitamin B12 deficiency and their appropriate use for megaloblastic anemia. Also, the pharmacology of anaerobic growth factor involved in erythropoiesis and the name drug used in treatment of sickle cell anemia. So, we have three main parts in this lecture. First part about the iron deficiency anemia, second part about the vitamin deficiency anemia, and third part about red blood cell deficiency anemia. So let us begin with lecture by introduction about anemia. So what is the definition of anemia? It is defined as low in hemoglobin concentration due to either reduced production or increased loss of the RBCs. And it is defined by the WHO as hemoglobin is less than 13 gram per deciliter in men, while it is less than 12 gram per deciliter in women. The most common causes of anemia is iron deficiency anemia. Let's take so the iron deficiency is the most common cause of anemia, and actually the total amount of transferrin, which is a protein present in the blood and binds to the iron, it determines the total iron binding capacity of the plasma. And through a certain ratio between the plasma iron over the total iron binding capacity, that's called transferrin saturation, which is normally from 20 to 50%, it gives us a useful index about the iron status. How is that? Let's see. In cases of iron deficient states, there's actually decline in the plasma level with iron, and so there will be increase of the total iron binding capacity. So transferrin saturation would be less than 20%. The opposite will occur in cases of increased iron overload, like hemochromatosis, where this iron overload is excess and iron can be deposited in different organs. Let's see about the iron itself. For absorption of iron, iron is absorbed actually from the upper small intestine in the ferrous state. It favors the absorption of the ferrous state more than the ferric state. About 10% of that iron is absorbed. So we need to know the factors that increase absorption and the factors that decrease the absorption. The factors that increase absorption, like pregnancy and the growing infants, where there is need of intake. Also, presence of gastric HSL enhance the iron absorption. Also, the presence of vitamin C, which is very important to be taken with the iron therapy, it also increase the absorption of iron. The factors that decrease the absorption, like antacids or tannic acid present in tea, or tetracyclines, all these can affect and decrease the iron absorption. Especially we are talking about drug-drug interaction like antacids or tetracyclines. About the transport, actually, in the plasma, iron is transported through the protein called transferrin and is stored in the reticuloendothelial system and the bone marrow as ferritin. For excretion, actually, there is no active mechanism for excretion of iron, and only very small amounts are excreted through the small urine and sweat. So the main regulation of the iron level in the body is done through the level of the absorption. This diagram presents the whole process of the iron in the body. First, take of the iron is absorbed through intestine, as we see, then passed to the blood. In the blood, we have many pathways. Can be utilized by the bone marrow to form RBCs, and go after that to the endothelial system where it is stored or engulfed by macrophage. And also it can be used in stored in the form of ferritin, diamocyrine, or utilized in myoglobin and enzymes, and a few amount is lost in the urine, stool, and sweat. So what are the indications of iron therapy? Indication of iron therapy with to prevent or treatment of iron deficiency anemia caused by many things. First, deficient intake, like decrease in intake per diet, or this problem in absorption like malabsorption syndrome. Second, increased demand. The body needs a lot of iron, like in cases of pregnancy or in case of premature babies. Also, if there is excessive blood loss, like bleeding, if someone exposed to trauma or accident and lost a lot of blood, I need to give him iron therapy. So first, prevention and or treatment of iron deficiency anemia. In case of deficient intake, increased demand and excessive blood loss. Second indication with other types of anemia to prevent the consumption of iron stores. As in another type of anemia, there is need of iron, and so it will decline the iron stores. We'll see the types or forms of iron given. We have two types, oral and rectal. In case of oral iron therapy, we have many forms. Ferrous sulfate, which is the most common and it is low cost. Ferrous gluconate, ferrous fumarate. We have another new one, it's called the polysaccharide iron. It can be given once daily, and actually it is similar to twice daily dose of ferrous sulfate, and so it will show more compliance with the patient and accessible to patient easily. Vitamin C may be given with iron to improve absorption, and so I can give you a question about the use of iron or the value of vitamin C to be used or taken with iron therapy. Actually, after take of iron, hemoglobin will reach its normal level within about 1 to 2 months, but actually treatment should be continued for at least 3 to 6 months to replenish iron stores. So hemoglobin will be reached in 1 month, but actually treatment should be given at least for 3 to 6 months. And we'll do something like CBC evaluation or hemoglobin evaluation every month to get the level of the hemoglobin and the improvement of treatment. So let's see the adverse effect of this oral iron. First, it will affect GIT as iron is very irritant, can cause result in nausea, gastric pain. Actually, iron increase HCl secretion, and so can cause also affect gastritis, can affect intestine causing abdominal cramps, constipation, or diarrhea. And all these effects can be minimized by taking iron after meals. So also it is a question. Explain iron should be given after meals to minimize these side effects. Second thing, one of the bad effects of the iron, dark stools. And the stool will look black. And this may make us diagnosis problem for something like GIT loss like melena. Melena is a sort of blood loss from the GIT. And actually it causes black stools or dark stools. And so it gives us a misdiagnosis of the melena. Also, I need to give the patient information about this problem as it will affect his behavior about this dark stool. Why my stool become dark? So I should give him assurance of this problem. Third, metallic test. It cause something like metals in the mouse. And is the bad some sort of bad test? Not a good one. Also, may cause staining of the teeth. Okay, staining of the teeth. So these are the adverse effects of the oral iron. The most common and the most important is the GIT, dark stool, metallic taste, and staining of the teeth. Let's proceed to the parental iron therapy. When I need to use parental it means by injection. When there is a problem through the oral pathway, inability to tolerate or absorb oral iron, there is a problem through the use of oral iron. If the patient has a great peptic ulcer or a problem can't tolerate the use of oral iron, so I need to proceed to use alternative pathway through the parenteral iron therapy. Second one, when I need to intake or give iron in a large amount, especially in case of severe anemia or there's extensive bleeding and great loss of blood. And this will need a lot of time to be corrected by the oral iron. So I need here emergency condition. What are the preparation? We have two preparation. Iron dextran complex and can be given by intramuscular or intravenous. Iron saccharose, which is given only by intravenous, and it is less allergic than iron dextran. There is important precautions regarding the parenteral iron therapy. First, we need to give a test dose for the hypersensitivity reaction because somebody may be allergic and this will cause a great problem to him, like anaphylactoid shock. Also, deep intramuscular injection, and this to minimize the local pain and also to minimize the tissue staining following the injection site. Again, for the precautions, take this dose is a must for hypersensitivity reaction to avoid the hypersensitivity reaction, as some patients may have hypersensitivity reaction and anaphylactoid reaction to the parenteral iron therapy. Second one, give it not intramuscular injection only, but it is deep intramuscular injection. If I give intramuscular, it should be deep. For two things. First, to decrease the local pain. As I said, iron is very irritant. And second thing, iron making tissue staining, so I need to decline this tissue staining following the injection site. So let's proceed to the last point of iron. Is about iron toxicity. Iron toxicity may be acute or chronic. Let's see the acute. In case of acute, it occurs accidental, especially in children when they ingest by accident iron capsules. Iron is very irritant to the children and will affect their GIT, causing necrotizing gastroenteritis and will result on shock and acidosis. In this case, we have many lines of treatment, but the most important is to remove the iron from the body by using the iron chelating agent, what's called desferrioxamine. It is given by intramuscular injection. It will bind to the iron and remove it from the body and get rid of the iron from the body. In case of chronic, it occurs in case of hemochromatosis, so there is iron deposition in different organs, or through the frequent blood transfusion, in case of the patient with needing frequent like blood diseases. In manifestation occurs here through iron will be deposited in different organs like liver, heart, and pancreas. Treatment actually is not like the acute, actually. We have the main line of treatment by what we call venesection. Venesection means that I make incision in the vein and remove a certain amount of blood. This will be done every week until the level of the iron will be returned to normal. If this cannot be done in certain situations, we will give periodic desferrioxamine intramuscular only when venesection or phlebotomy cannot be performed. This is what the picture of the venesection, where I remove a certain amount of blood every week until the level of the iron will be normal, return it to normal. If there is no, can't use this method in case of patient with blood disease, I will give periodic use of desfluxamine every week for a certain dose intramuscular injection until also blood level of iron returns to normal. Let's go to what we call vitamin deficiency or megaloblastic anemia. Megaloblastic anemia, what we call macrocytic anemia. Macrocytic means that large cells. Here, the anemia RBCs become large in size. And actually, it results from the failure of DNA synthesis during RBC's development. This failure of DNA synthesis leads to continuing cell growth without division, and so they appear large in size, but actually they are not functioning. Actually, the defect in red cell DNA synthesis due to deficiency of vitamin B12 and or folic acid. Start with vitamin B12, what we call cobalamin. The source of cobalamin by vitamin supplements in the form of cyano or hydroxycobalamines. The absorption of vitamin 12, it needs intrinsic factor. It is a protein made by the stomach brittle cells that bind to vitamin B12 and deliver it from the ileum via calcium-mediated events. So intrinsic factor is essentially for the absorption of vitamin B12. It binds to the vitamin 12 and it is absorbed through the ileum. It helps the absorption of vitamin B12 through the ileum. If there is deficiency of this intrinsic factor, it is called here pernicious anemia. And actually, it is a lifelong problem. And the patient needs to take vitamin B12, the active form of vitamin 12, along all their life. Vitamin 12 is stored in the liver in large amount. That's enough for 3 years. You see the journey of the vitamin 12 here. The vitamin 12 is going through the stomach. Here is the intrinsic factor that is essential and is secreted by the brittle cell in the stomach. So the intrinsic factor here binds to the vitamin 12 and so until it reaches the ileum. Here the ileum, it allows the absorption of vitamin 12. Vitamin 12 is essentially for the activation of the folic acid to be converted from the dihydro to tetrahydrofolic acid, which is the active form of the folic acid, and this more involved in the DNA synthesis. Vitamin 12 is stored in the liver, and this storage is supplied for the 3 years. What is the essential or the important roles of the vitamin B12 in our body? Actually, vitamin B12 is essential for RBCs, neurological functions, and DNA synthesis. So deficiency of vitamin B12 will result in, first, the blood will result in megaloblastic anemia. On the GIT, will result in sore tongue, abnormal GIT epithelium. On the CNS, neurological, cause degeneration of the brain, spinal cord, and demyelination of the nerve sheath. You see the diagram that's showing. This is the sore tongue caused by deficiency of vitamin B12. Sore tongue here. Other problems associated, neurological manifestation, megaloblastic anemia, and others. So what are the uses? First, included in the megaloblastic and pernicious anemia. In case of megaloblastic anemia, the improvement in hemoglobin will be appear in just 7 days and normalized in 1 to 2 months. While in case of pernicious anemia, the treatment must be given a lifelong treatment. The second part in case of peripheral neuropathy, especially in case of elderly or diabetic neuropathy. So let us see the folic acid, the second part of megaloblastic anemia. It is also named as vitamin B9, leucovorin, other names for folic acid. Absorbed folic acid from diet requires reduction by dihydrofolate reductase to the active form tetrahydrofolate. This active form is needed in the DNA synthesis. Deficiency of folic acid results in megaloblastic anemia. It's more common with folic acid deficiency than vitamin B12 deficiency, and actually it occurs after 4 months of folic acid deficiency. Second problem that occurs from folic acid deficiency actually during pregnancy. So that's why folic acid is essential to be taken during pregnancy. It will lead to insufficiency in the neural tube defects. The uses therapeutic use of folic acid. The first one, in case of to treat the megaloblastic anemia, due to inadequate dietary intake of folic acid. Also, due to diet reductase inhibitors, drug problems like methotrexate or tritimoprid. Either will inhibit dihydrofolate reductase enzyme, which is essential for the activation of the folic acid. Second one, routine prophylaxis during pregnancy. As we said, deficiency of folic acid will lead to neural tube defects, and so it will be given as a routine during pregnancy to prevent the occurrence of neural tube defects, which is called spinal bifida. Notice about the folic acid. When I give folic acid alone, it will reverse the hematological abnormality and thus it will mask the vitamin B12 deficiency, which can then proceed to severe neurological dysfunction and disease. And so, in case of megaloblastic anemia, it shouldn't be treated alone with folic acid, but we give a combination of folic acid and vitamin B12. That's very important when I give case of folic acid deficiency. Let's proceed to red cell deficiency anemia. Erythropoietin. Erythropoietin, it stimulates the RBC's production through decreasing apoptosis and enhancing division and differentiation of thyroid progenitors in bone marrow. Actually, we have a preparation of the erythropoietin. This is a human source that is made by RNA technology. It's called the glycoprotein alpha. It is given by either subcutaneous or intravenous. It will be given in case of anemia due to chronic renal failure. See the diagram. In case of kidney problem, there is what we call normocytic pneumochromic anemia. And this anemia is caused by deficiency of erythropoietin. And so this give erythropoietin therapy to stimulate the bone marrow to form the RBCs or new RBCs to correct the anemia. Let us see the adverse effect of erythropoietin therapy. First, utilization or the formation of the RBCs will utilize the iron storage and so means expose the patient to iron deficiency anemia. So I need to give the patient iron during this correction of anemia due to chronic renal failure. Second, there is increased risk of blood pressure and they may expose the patient for hypertensive crisis. Also, there is increased production of platelets and this may expose the patient with risky for thrombosis. Other side effects like flu-like symptoms or seizures can occur with erythropoietin. Seizures means that convulsions. Last one is about hydroxyurea. It is an oral ribonucleotide reductase inhibitor. It can reduce the frequency painful sickle cell crisis. It is given in case of sickle cell anemia. As hydroxyurea, it increases the formation of fetal hemoglobin, and this will dilute the abnormal hemoglobin S. So hydroxyurea is used only in sickle cell anemia. Questions. Next problem for questions from question 1 to 4. A 23-year-old pregnant woman is referred by her obstetrician for evaluation of anemia. She is in her fourth month of pregnancy and has no history of anemia. Her grandfather had pernicious anemia. Hemoglobin is 10 gram per deciliter, normal range between 12 to 16 gram per deciliter. Question 1. If this woman has macrocytic anemia, an increased serum concentration of transferrin and a normal serum concentration of vitamin 12. The most likely cause of hair anemia is deficiency of which of the following? Cobalamin, erythropoietin, folic acid, intrinsic factor, iron. Question 2. If the patient in question 1 had deficiency identified, 11 would have a higher than normal risk of which of the following? Cardiac abnormality, congenital neutropenia, kidney damage, limb deficiency deformity, neural tube defect. Question 3. The root data for your pregnant patient indicate that she doesn't have macrocytic anemia, but rather microcytic anemia. Optimal treatment of normocytic or mild microcytic anemia associated with pregnancy uses which of the following? A high fiber diet, erythropoietin injections, ferrous sulfate tablets, folic acid supplements, hydroxycolamine injections. Question 4. If this patient has a young child at home and is taking iron-containing prenatal supplements, she should be warned that they are a common source of accidental poisoning in young children and advised to make a special effort to keep these pills out of her child's reach. Toxicity associated with acute iron poisoning usually includes which of the following? Dizziness, hypertension, and cerebral hemorrhage, hypothermia, delirium, and coma, hypotension, cardiac arrhythmia, and seizures, exciting gastroenteritis, shock, and metabolic acidosis, severe hepatic injury, encephalitis, and coma. Question 5. Which of the following is most likely to be required by a 5-year-old boy with chronic renal insufficiency? Cyanocobalamin, deferoxamine, erythropoietin, folic acid, iron, dextran. Question 6. The patient has been taking ferrous sulfate twice daily for 2 weeks and is complaining of a bad taste after each dose. Which one's daily oral iron formulation would improve tolerability and provide a similar total daily dose of elemental iron as twice daily ferrous sulfate? Ferrous ferric ammonium citrate, ferrous gluconate, ferrous sulfate anhydrous, polysaccharide iron complex, ferrous fumarate. Reference. Thanks.